We've got a clinical case, my beloveds. 72-year-old man with a history of hypertension, 72, and type 2 diabetes, presents with palpitations and mild shortness of breath. Okay. ECG shows atrial fibrillation. His blood pressure is stable and there is no signs of heart failure. Which of the following is the most important step in preventing a major long-term complication? No, I understand it's a stroke prevention. Option A, start beta blocker for rate control. No. Prescribe anticoagulation with direct oral anticoagulant, that is. And C, plan immediate electrical cardioversion. So rhythm control mafia. No. Low dose aspirin daily. No, of course, prescribe anticoagulation, option B, with the direct oral anticoagulant. That's because stroke prevention with anticoagulation is the most important intervention in atrial fibrillation, guided by the CHA₂DS₂-VASc score. Yes, my beloveds. If you want, I can explain why other options are incorrect. Start beta blocker. So what we have? We have 72-year-old man, 72-year-old man, hypertension, diabetes, and atrial fibrillation. Hemodynamically stable, actually, no heart failure. Anyway, start beta blocker for rate control. Why not correct? Rate control with beta blockers is important for symptom management, palpitations, dyspnea, no heart failure signs. But the most important issue is not just the rate, but preventing stroke, of course. Beta blockers do not reduce stroke risk. They are not the priority intervention. Actually, after oral anticoagulant or with, we can prescribe, why not, these beta blockers. Prescribe anticoagulation with a direct oral anticoagulant, yes, because atrial fibrillation increases ischemic risk fivefold. And we have guidelines, age more than 65, hypertension, diabetes, so anticoagulation is mandatory and least contraindicated, of course. And this is the single most important measure for long-term survival and morbidity prevention. Plan immediate electrical cardioversion indicated only if the patient is hemodynamically unstable, so hypertension, pulmonary edema, and severe angina. In this case, the patient is stable. Moreover, if atrial fibrillation duration more than 48 hours is uncertain, cardioversion with anticoagulation risk, embolic risks without anticoagulation, risks embolic stroke. Okay, remember that, my beloveds, if atrial fibrillation duration is more than 48 hours and you are not sure that it's recent or not recent, cardioversion without anticoagulation risks embolic stroke. Thus, not the right first step at all. Option D, low dose aspirin daily. No, aspirin was considered, but studies showed it's not effective enough in stroke prevention compared to coagulation. Yes, a little bit controversial, but anyway, now we said it's not so effective as anticoagulation. In guidelines, aspirin is no longer now recommended for stroke prophylaxis in atrial fibrillation. So in summary, what we've got? We've got anticoagulation is the cornerstone, my beloved, of atrial fibrillation management in high-risk patients. Rate rhythm control improves symptoms but doesn't prevent stroke. Aspirin, now we can say it's inadequate, and cardioversion is only for unstable patients or elective after anticoagulation. No, it depends. Okay, so we start with anticoagulation. My opinion, this person after anticoagulation or with anticoagulation, we can prescribe everything for depending. I will be prescribed beta blocker, but anyway. We do not start with beta blocker, we start with primary anticoagulation. Get it? Good.